Hello everyone. Today we will discuss about one of the microvascular complications of the diabetes, that is diabetic nephropathy. Coming to the definition of diabetes nephropathy. So diabetic nephropathy can be defined that it is a condition when there is presence of albuminuria and or reduced estimated glomerular filtration rate, and both this condition or either of this condition will be present when there are absence of signs or there are absence of any primary causes for kidney damage in any patient of diabetes. And globally it is seen that approx 20 to 40% of the patient who are ill with diabetes, they develop nephropathy, and this nephropathy can develop in both type of diabetes, type 1 and type 2 diabetes. It is also seen that in such kind of patient who develop diabetic nephropathy have concomitant retinopathy also. In a patient with diabetic nephropathy, the proteinuria means secretion of protein in the urine is the one of the initial sign in such patients, and this patient later on goes towards the progressive renal damage, and this progressive renal damage leads to decrease or decline in the glomerular filtration rate, and this condition is known as renal failure and end stage renal disease. For diabetes nephropathy, there are some other terms like diabetic kidney disease or chronic kidney disease. It is also found that this diabetic nephropathy is one of the strong predictor of the cardiovascular mortality, and this diabetic nephropathy is developed after a series of events, series of stages. However, in the initial stage, early stage, this diabetic nephropathy remains undetected. When we see the characteristic feature of this diabetic nephropathy, so this include persistent proteinuria, means persistent secretion of proteins in the urine. There will be reduction in the glomerular filtration rate, and the BP, that blood pressure, will be elevated in such kind of patients. This diabetic nephropathy is one of the leading cause of chronic renal failure, which is also known as end stage renal disease in the world. Why? Because nowadays there is increase in the prevalence of type 2 diabetes mellitus in the world, and as there are many therapeutics options are available nowadays, which leads to such patients to live longer, and as their life is long, there is increased chances to develop chronic complications in such patients, including the kidney disease. However, it is seen that only 20% of the patients with type 2 diabetes mellitus, they reach to this end stage renal disease. Why? Because as we have already studied that this diabetic nephropathy is one of the indicator for the cardiovascular mortality. So many of such patients, they die in their early life due to coronary artery disease before reaching to this end stage renal disease condition. So in type 1 diabetes mellitus, there is increased chances of morbidity and mortality, which includes that about 35% of the patient, they reach towards the end stage renal disease or chronic renal failure. About the natural history of this kidney disease in type 1 diabetes mellitus was first described by the scientist. His name is Mogensen, and the natural history of this kidney disease has been depicted in this picture. It is found that the patient with diabetes, they have 17 times more prone to develop kidney disease as compared to the general population who are not having diabetes. And it is also seen that in type 1 diabetes, this peak onset of diabetic kidney disease is most common between the 10 to 15 years after having the diabetes. And if in a patient with type 1 diabetes mellitus, there is development of overt proteinuria, means when the albuminuria, means albumin secretion in urine, is more than or equal to 300 milligram per day. So it means that about 50% of the diabetic patient, they will definitely reach to end stage renal disease in their 10 years of having disease. And it is also seen that about 75% of such patient will definitely reach in condition of end stage renal disease within their 20 years of having diabetes. The hallmark of this diabetic kidney disease is glomerular basement membrane thickening, and it also involves the capillary endothelial cells as well as tubular epithelial cells. There are various mechanisms when there is thickening of the glomerular basement membrane, and this mechanism include: the first one is excessive permeability of this glomerular basement membrane for the plasma proteins, and this excessive permeability may be due to the non-enzymatic glycosylation of the plasma proteins, or it may be due to the decrease in the anionic changes of the glomerular capillary wall, and it may be because of the loss of size selectivity in the glomerular capillary wall. The second mechanism behind this glomerular basement membrane thickening is trapping of the macromolecules, and it may be due to the cross linking of the proteins, and which ultimately lead to formation of the advanced glycation end products. The third mechanism behind this thickening of the glomerular basement membrane is increased cellular proliferation and matrix, and this is because of the release of growth factor like interleukin 1 and TNF, tumor necrosis factor, and this is followed by the activation of the macrophage by the advanced glycation end products. And for this glomerular hyperfiltration, these are some possible mediators, for example hyperglycemia, insulinopenia, excessive growth factor, hyperglucagonemia, etc. Coming to the risk factors for this diabetic nephropathy, so the first one is the age. It is found that older people have higher chances to develop diabetic nephropathy. It is also found that if any person is having a family history for development of this chronic kidney disease and acute kidney disease, so there is higher chances of such persons to develop diabetic nephropathy. If any person is having poor glycemic controls, means there is increased HbA1c level, means that the glucose level in the blood is not controlled properly. So in such person, higher chances of development of diabetic nephropathy is there. It is also linked risk factor with elevated BP, hypertension is there. If any person is obese, then there are higher chances. Whenever there is a dyslipidemia present, then it will also lead to development of nephropathy. If any person have history of smoking or he is a chronic smoker, then it is also a risk factor. It is also found that the men have higher chances to develop nephropathy as compared to the women. And if any person consume high protein diet, then in such person also have higher chances to develop diabetic nephropathy. Coming to the pathophysiology of diabetic nephropathy, so it is found that the renal tissue, they are highly susceptible to hyperglycemia. That's why this hyperglycemia badly affect this renal tissue. The end organ damage or the structural damage of renal tissue because of this hyperglycemia, that includes many cellular engineering mechanism, and some of the mechanisms are oxidative stress, growth factor, transcription factor, and this cellular mechanism also involve the few of the inflammatory cells. Those are monocytes, lymphocytes, macrophages. Coming to the clinical progression in diabetic nephropathy. So this clinical progression in diabetic nephropathy can be explained to the 5 stages, and these 5 stages have their own characteristic clinical feature. They have their own typical histopathological changes, and also the varied pattern of progression in individuals has been seen. This histopathological changes in this diabetic nephropathy, in this each stage shows their distinct unique histopathological changes, and it is also seen that the patient with type 2 diabetes mellitus have their greater heterogeneity in their pathology, and the predictability is also lesser in respect to the progression. Now let us discuss to the stage 1 of this clinical progression. So this stage 1 is known as early hyperperfusion, and this stage 1 is usually present when the diabetes is diagnosed, and histopathological changes seen in this early hyperperfusion are there will be thickening in the glomerular basement membrane. This stage 1 is characterized by there will be increase in the glomerular filtration rate. Albuminuria will be present, but it will be in a mild condition, and this albuminuria in stage 1 can be aggravated by the exercise. However, there will be no any clinical feature present in this stage 1. Coming to the stage 2, it is known as silent stage. The histopathological changes are expansion in the mesangial matrix, damage to the podocytes, and this stage is characterized by that morphological changes will be present in renal tissue. However, the clinical features are still absent in this stage also. In this stage, there will be no albuminuria. However, when there is adequate glycemic control is there. In respect of GFR, this will be either normal or it will be found increased. Albuminuria will only found during the exercise when there is poor glycemic control. Coming to the third stage of this clinical progression of diabetic nephropathy. So this stage 3 is known as incipient diabetic nephropathy. The histopathological changes are subendothelial deposits will be there. Hyaline arteriosclerosis will be present. Reduction in the nephrin expression in this stage, and there will be hypertrophy of the glomerular tissues will be seen. This stage is characterized by decrease in the GFR level, increase in albuminuria, and the first time in this stage we will found some clinical features in form of increase in blood pressure. Coming to the stage 4, that is known as overt diabetic nephropathy, the histopathological changes found are deposits in the subendothelial tissues, mainly in the Bowman's capsule, some endothelial deposits in proximal tubules, glomerular fibrosis will be found, there will be tubulointerstitial fibrosis in this stage. This stage 4 is characterized by below normal glomerular filtration rate. We will find persistent proteinuria, and this proteinuria will be more than 0.5 gram per 24 hours, and again we will find here a clinical feature in form of high BP. Coming to the last stage, that is stage 5, which is known as end stage renal failure. This stage in this stage 5, the diabetic nephropathy may also cause the acute kidney injury in some individuals, and this acute kidney injury is a condition when there is renal function is deteriorated rapidly in a short period of time. The histopathological changes in this stage are glomerular sclerosis, tubulointerstitial sclerosis, and this stage is characterized by uremia, means there is increased raised level of the urea in the blood, and ultimately the patient reaches to end stage renal disease. This table shows the summary of all the stages of this clinical progression of diabetic glomerulopathy. So in stage 1 there will be hyperinfiltration or hypertrophy will be present, followed to that normal albuminuria, then we will found microalbuminuria, and in stage 4 overt proteinuria will be seen, and ultimately patient will reaches to end stage renal disease condition. In structural changes, initially there will be glomerular hypertrophy, then the increase in the glomerular basement membrane thickness will found, and in the final stage there will be closure in the glomerulus. In respect of GFR, glomerular filtration rate, initially in stage 1 it is normal, in stage 2 this GFR will enhance to 20-30%, in stage 3 also this GFR will be found in increased level. However, from stage 4 we will found decrease in the GFR. In respect of urine albumin excretion, in stage 1 initially it will increase, in stage 2 it will be in normal condition. After that this urine albumin excretion will rise, initially 20 to 200 microgram per minute, then finally more than 200 microgram per minute. In stage 1 and stage 2 the BP will be normal, no clinical feature will found. However, from stage 3 we will found increase in the BP level, and ultimately in the stage 5 we will found that person is having hypertension. This table shows the values which define this abnormal albumin excretion rate. So the normal level of this albumin is taken in two conditions, can be taken in two conditions, the spot collection or 24-hour collection. So the normal albumin excretion level can be defined when it is less than 30 microgram per milligram of creatinine. If this level is between 30 to 299 in this both situation, spot collection and 24-hour collection, then it is defined as microalbuminuria, and when this level is increased more than or equal to 300 microgram per milligram of creatinine, then this condition is known as macroalbuminuria. However, the American Diabetes Association, they have recommended that these two stages, the microalbuminuria and macroalbuminuria, should be combined as a single stage, and this should be known as abnormal urinary albumin excretion. Now discussing to one of the important term, that is acute kidney injury, AKI. As we have already discussed that this AKI is a condition when there is sudden deterioration in the renal functions over a very short period of time. And when we see the risk factors for this acute kidney injury, so these are the stage 5 diabetic nephropathy, when the person is already having any pre-existing renal disease. There are some medications which also lead to acute kidney injury. Those are some NSAIDs, some diuretics, antihypertensive like ACE inhibitors, and few antibiotics. If any person is having heart disease, it is also a risk factor for development of acute kidney injury. This diagnosis of the acute kidney injury can be done by measuring the sudden increase in the serum creatinine level, and also there will be concomitant fall in the eGFR values. Now let's discuss how this condition of diabetic nephropathy is diagnosed. So the first condition is microalbuminuria, which is usually found in stage 1, 2 and 3 of the clinical progression of this nephropathy. However, this persistent microalbuminuria will found in stage 1 and 2 and 3. When we see the GFR, so in stage 1, 2 and 3 we will found normal or increased GFR. However, we will found reduced GFR in stage 4 and 5. The condition of hypertension will be found in stage 4 and 5. However, there will be no clinical features in stage 1, 2 and 3. Now discussing to screening for this diabetic nephropathy. So as per the American Diabetes Association guidelines, the annual screening recommendation for various stages or various conditions of this diabetic nephropathy are as under. The annual screening is recommended when the person is having type 1 diabetes, and this type 1 diabetes is for more than 5 years. If any person is having type 2 diabetes mellitus and along with he is also having hypertension, then we will recommend for annual screening. When person is have already developed the complications of diabetic nephropathy, then this annual screening should be considered. In stage 3 disease, the screening should be done once in 6 to 12 months. In stage 4, the screening should be done in every 3 to 5 months. For stage 3, the screening should be done in every 1 to 3 months, means more frequently this screening should be done. And these are the tests which are used for the screening of this diabetic nephropathy. The person is required to get his physical examination done, blood pressure recording of the albuminuria, and GFR estimation is also carried out. Coming to laboratory parameters for screening of diabetic nephropathy. So this diabetic nephropathy can be diagnosed by a few abnormal values for the when there is urine albumin to creatinine ratio, UACR, is more than or equal to 30 milligram of per gram creatinine, and or the estimated glomerular filtration rate, that is eGFR, is less than 60 milliliter per minute per 1.73 meter square, then in both the conditions we can say the person is having diabetic nephropathy. The measurement of urine albumin may be affected by the 24-hour urine albumin measurement and by urine albumin to creatinine ratio in spot urine sample. And measurement of this 24-hour urine albumin measurement is a very hard task, very cumbersome test, and this urine albumin measurement can be affected by the level of hydration of the person and when there is concentrated urine. To avoid the biological variables and to confirm this condition of albuminuria, we need to repeat our measurements, and when there is 2 samples are abnormal out of 3 samples and within the 3 to 6 months period, then in this condition we can say that the person is having albuminuria. This urine albumin level can be affected in various conditions like exercise, in a condition of infection, fever, when there is congestive heart failure, and also during the menstruation. Now let's discuss about the complications of diabetic nephropathy. So the person with diabetic nephropathy can have elevated BP, as we have seen that it is very common after the stage 4 and 5, and this can be diagnosed by the measurement of this BP. Person can have volume overload, which can confirmed by the physical examination and measurement of weight. There can be development of electrolyte abnormalities, which can diagnosed by the serum electrolytes level. There can be metabolic acidosis also, that can be confirmed by the measurement of electrolytes level and calculation of the pH. Person can also develop anemia. We can diagnose this by the measuring the hemoglobin level. Metabolic bone disease can develop, can be confirmed by the measurement of calcium, phosphate and vitamin D levels. Also there are high chances to for the infection, and also the cardiovascular diseases can arise in such diabetic nephropathic persons. There is a condition which is known as non-diabetic renal disease. These conditions are potentially curable as compared to diabetic kidney disease, which are usually not curable. However, these are controlled only. The clinical clues by which we can diagnose the presence of this non-diabetic renal disease are that there will be short duration of diabetes, which is usually less than 5 years in such persons. Retinopathy will be absent in such non-diabetic renal disease conditions. There will be elevated lipid levels, and history of renal disease will be present prior to diagnosis of the diabetes. Now let's discuss of association between the diabetic kidney disease and pregnancy. When there are microalbuminuria and proteinuria during the pregnancy, condition of pregnancy, so it will be poor prognosis for the both mother as well as for the fetus, as this condition can lead to development of the preeclampsia. And as we know that during the pregnancy, the antihypertensive drugs like angiotensin converting enzyme inhibitors and angiotensin receptor blockers are contraindicated. So in this condition, we can give the pregnant mothers antihypertensive drugs like calcium channel blockers for the control of hypertension. These are the few complications listed which can be present in a pregnant lady if she is diabetic and she has developed the condition of this diabetic nephropathy. So these complications are higher chances for the perinatal and neonatal mortality, higher chances of congenital malformation development, increased risk for the development of eclampsia and preeclampsia, and also in such pregnant ladies the chances of cesarean section will also be increased. Coming to the treatment for this diabetic kidney disease, so the first method of treatment is glycemic control. It is found that intensive glycemic control can reduce the risk of development of diabetic kidney disease. The prescription of metformin depends upon the level of eGFR. If eGFR level is 45 ml per minute, then we can prescribe full doses of metformin to the patient. If this eGFR level is approx 30 ml per minute, then we can reduce the dose of metformin, and if the eGFR level is below 30 milliliter per minute, then this metformin is contraindicated. These sulfonylureas can be used in case of renal insufficiency, as the meglitinides can also be used in such renal insufficiency case. Insulin is the mainstay of therapy when the person is having moderate to severe renal impairment. Apart from that, the newer drugs like DPP-4 inhibitors can also be given in reduced doses for these diabetic kidney diseases. The second mode of treatment is dietary modification. So the individual which are having kidney disease can restrict their protein diet to 0.6 to 0.8 gram per kg per day, which can inhibit the progression of this renal damage. The restriction of sodium intake can also reduce the risk of this diabetic kidney disease, and the restriction of sodium intake is required to be less than 2300 milligram per day, which will help for the control of BP as well as the fluid load. However, the restriction of protein intake is not indicated for fear of inducing malnutrition. In the treatment modalities of this diabetic kidney disease, the BP control is one of the important steps. So all the patients with diabetes, the target BP will be below 140 by 90 mmHg, and the drug of choice for these diabetic patients which have developed the albuminuria and hypertension, the drugs of choice are ACE inhibitors and angiotensin receptor blockers. If this ACE inhibitors and angiotensin receptor blockers are not able to control the BP, then we can also use some other agents like loop diuretics, calcium channel blockers, alpha blockers and beta blockers. If the serum creatinine level is more than 3 mg per deciliter, or the creatinine clearance is less than 30 ml per minute, in such condition we should avoid prescribing ACE inhibitors and angiotensin receptor blockers. Apart from this BP control, there are some other aspects for the management of this diabetic kidney disease, like we should avoid the nephrotoxic drugs and radio contrast media. We should avoid conditions like dehydration, and also we should avoid the smoking. Whenever there are urinary tract infection, then we need to treat such condition aggressively. If there is lipid abnormality, then we can start the statin therapy in such patients. However, the use of fenofibrate should be very cautiously, because it can raise the serum creatinine levels. For the treatment of end stage renal disease, the treatment options are hemodialysis, the peritoneal dialysis, and renal transplantation. And there are some future prospects for the treatment of diabetic kidney disease. These are use of aldose reductase inhibitors, the endothelin receptor antagonist, the protein kinase C inhibitors, the mineralocorticoid receptor antagonist. Now coming to the summary of all this presentation, that the diabetic nephropathy is one of the leading cause of the end stage renal disease and chronic kidney disease. The microalbuminuria is the earliest sign of development of this diabetic nephropathy. Albuminuria is one of the indicator or predictor of cardiovascular disease development, the development of end stage renal disease, as well as the mortality. These are the abnormal values by which we can diagnose the condition of diabetic nephropathy. Urine albumin creatinine ratio is more than or equal to 30 milligram of per gram creatinine, and if the eGFR is less than 60 ml per minute per 1.73 meter square. Thanks for watching this video. If you have liked this video, please share with others.